My name is Roger Lee from the Moffitt Cancer Center. Here we are at SUO 2024, and I have three distinguished experts with me here. So we'll just kind of go around and first have each of you introduce yourselves, and then we can have a conversation about bladder cancer. So,
Vitaly Margulis, yes, Vitaly Margulis. I'm local at UT Southwestern in Dallas, and urologic oncology, and about half my practice is bladder cancer.
I'm Kyle Rose. I'm a urologic oncologist from Ochsner, also specializing in bladder cancer.
So, Paul Crispen. I'm a professor of urology at the University of Florida, and I also serve as the Associate Director of Clinical Research for the UF Health Cancer Center.
Great. It was great to have all of you here with us today. So, we're talking about one of the topics that's near and dear to my heart, and I'm sure to yours as well, high-risk non-muscle invasive bladder cancer. So just to start things off, with the BCG shortage and such, Vitaly, are you still kind of going to BCG for all of your high-risk NMIBC patients?
So generally in a large academic practice, we've been relatively sheltered from the BCG shortage, but we made adjustments. And so, for example, we have in certain patient populations limited maintenance only to high-risk patients, not intermediate risk patients. We have now administered routinely 1/3 of the dose. But we see patients from the community who are affected by shortage and are giving treatments that are not BCG and perhaps a little bit off the standard of care.
Yeah. And what about you guys?
Oh, same. I think it's a month-to-month issue that we frequently check in when we have a patient with a new finding of high-risk non-muscle invasive bladder cancer. Fortunately, we've been able to give the induction courses, but we've also gone to 5 or 6 or 2 or 3. So it's really the maintenance for those high-risk patients that I think gets sacrificed first.
Yeah.
We've used similar strategies as well. Also, a big part of our practice is offering clinical trials. They've actually helped us provide BCG to patients who aren't eligible for those trials while still giving patients other alternatives along the way.
Yeah, and that's a great point that you raise. One of the more important trials that we're running at our center is the Bridge trial.
Sure.
So, what are your thoughts on Doce maybe becoming another option in the frontline setting?
We'll see. I think it's an outstanding trial run by Max Cates. It's accruing very well. It still has several years ahead of it. I think that's a great example. Another great example that will probably have results out much sooner is SWOG 1602. TICE BCG
Absolutely.
Versus Tokyo.
Tokyo.
With the arm of the vaccine before BCG as well, and so that may actually help us with the BCG shortage and introducing a new strain to the U.S. But I don't think those results are going to be out for another year or so.
Yeah.
I'll just echo what he said with the BCG shortage really drove us to select clinical trials in that space to help replace the need for BCG or, fill that deficit of the BCG shortage. So we always have something to offer patients, whether it's the standard of care or the, inside the arms of a clinical trial.
Yeah, I would say, as crazy as it sounds, BCG has been the frontliner standard of care for 50, 60 years now. We really don't fully understand how it works. We don't fully understand how to properly select patients, and we really haven't, until recently, I think, moved the needle, to improve upon BCG results.
Yeah. So, kind of projecting a little bit. Let's say if Doce does become another option in the frontline setting, how does that affect your choices of choosing? Drugs? Is it going to be BCG if a patient were to have a high-grade recurrence after Doce, or is it going to be one of these newer agents that we'll discuss in a little bit?
$1 million question. I think this may be dictated by the payers to some degree, right? I think there's several trials of Doce in frontline, right, first line space versus BCG refractory. And we have to look at the data, and I think they'll be data-driven, right? If there's clear-cut superiority to, Doce over BCG, and I think the question may be answered very quickly.
I guess, have you guys had any experience with Doce in the frontline setting? Either on a trial or just because of the BCG shortage, you're putting some of these patients first on Doce instead of BCG?
Absolutely. Yeah, we've had some patients who were BCG eligible, we did not have it available. They did not meet BCG unresponsive FDA criteria. We couldn't put them on a trial. We didn't have an agent available at the time, and we'll put them on Doce.
Yeah, I think to your question that you had asked Vitaly before, it's the selection of Doce versus BCG or other agents is really going to be down to toxicity, which agents patients are going to do better on, but also I think Vitaly brought up an outstanding point of selection, because right now we're just picking one. We don't have any really biomarkers or other information that is necessarily going to say what treatment they're going to do best on in terms of recurrence or otherwise.